Thank you, Jagdeep, for a really excellent talk. So I just want to start by saying to everyone, there's been quite a bit of chat about the results, etc. And Jagdeep is sharing these at a very early stage with us, so we're really quite privileged to hear that. The full results will be available in a peer-reviewed article at some point soon. And because this has been funded by the Wellcome Trust, which is a charitable organisation in the UK, they will be published open access, so freely available to everyone to download and read. There was a question about the timescale for that. And Jagdeep, do you want to talk about the timescale for academic publishing? This is something that we could talk forever about, probably.
Well, as you know, Dom, the timescales are entirely unpredictable. So the process is it's assessed by the editor and then sent for peer review. That we receive the feedback and have a chance to respond. And then there is the editor looks at it again. Often it goes back to the peer reviewers. So there is this sort of back and forth, which can go on for a period of time. So usually, often, it extends to several months, but the precise timeline is impossible to tell at the moment.
And I would probably add the minimum timeline for what you've just described is at least 6 months. I would say, in my experience, that's if everything goes through completely smoothly. So it's 6 months plus. David, with your expertise on cell biology, do you have any questions for Jagdeep from that presentation?
Yes, a few. Firstly, congratulations, Jagdeep. That was some excellent work and very, very well presented. I thought it was an outstanding presentation of all of the work you guys have been doing, and really great to see it all sort of in one collected presentation, as it were. I have a few queries. Injecting the anti-TNF into these nodules, you mentioned that there were sort of, I guess, various forms of fibroblasts and myofibroblasts, as well as immune cells and endothelial cells, so a whole mixed bag of cells in these nodules. What do you feel that you're primarily targeting? Is it the immune cells? Is it the myofibroblasts? What are you going after here, do you think?
So it's essentially the mechanism that's driving the myofibroblast development and sustaining their phenotype. So, and that's the immune cells. And when we published our paper in 2019 in Science Advances, we showed that it's really the TNF that's coming from the M2-like macrophages and the mast cells. So as you know, David, the M2-like cells are not typically associated with inflammation.
Right, they're associated with inflammation resolution, in fact, yes. Right.
Precisely. So it's not, so when we talk about inflammation, the inflammatory infiltrate, most people think of those as the M1 type macrophages. But remember, this is very different. This is not like the typical acute inflammatory disease, or indeed, the massive inflammation we see in inflammatory arthritis or psoriatic arthritis, etc. This is a very low grade but chronic inflammation that's localized. You only see it in the palm, in the nodules. And we also published data in the same paper showing that whilst there's slightly elevated at around 50 picograms per ml of TNF from those freshly disaggregated cells from the nodules, it's undetectable in the circulation in Dupuytren's patients compared to sex-matched controls.
So it's a very localized effect.
It's a very localized disease because you just don't get spillover into the circulation as you would see, for example, in people with inflammatory arthritis or inflammatory bowel disease, etc., when they're going through flare-ups.
I see. How many questions am I allowed, Dominic?
Can I take some from the audience and then come back to you, David? Is that all right? So we have a question from Wolfgang Guack, which is repeated in a similar way below as well. Jagdeep, you said several times that the injections are painful. How did the patients respond to that? And did you do anything? Were you able to do anything to reduce the pain of the injection?
Yeah, so any injection is painful in the palm because it's got a very high density of nerves and a large cortical representation. And those data were published in 2018 from those different preparations of anti-TNF compared to placebo. And interestingly, at that point, we found that this new formulation without the citrate, the pain levels were rather similar between placebo and the adalimumab. So it's not the drug that's causing the pain. It's just a needle being stuck into your hand and fluid being injected. So it is painful, but the great news is it's very short-lived. So soon afterwards, people report very low pain scores.
Okay, and related to that, Miko Ueno is wondering whether you think there might be a possibility for a non-localized treatment which would get rid of that direct injection pain.
Well, all the anti-TNFs currently available are injectables, so that there isn't an oral. But also, I think even if there were, that there'd be, you need to consider, how much would get to the palm, because we need to deliver high local concentrations, and our data clearly show that. So we need high levels in the nodule, and it should be sustained there for a period.
Okay, so it sounds like localized injection is going to be the way forward. Paul.
Thank you very much, Dominic. Thank you very much, Jagdeep, for this fantastic overview of the work that you have been doing in the last how many years. It's really coming from the bench, taking into the bed of the hospital, I would say. Now, we have seen other studies that have used drugs which are being injected locally, like steroids. And ultimately, the results of those studies have been, in the long run, disappointing, because the benefit of the injection was relatively short-lived. Is there anything to be said already about the TNF? What sort of studies would you need to do in the future to get more feedback?
So, Paul, I'm afraid some of your feed broke up, but from what I understand, you're saying that there are existing data suggesting that, for example, with steroids, the effect is not durable, and you're asking me whether it's what it might be for anti-TNF. I think the first thing to say is I'm not aware of any controlled studies for steroids. So there's no placebo group, there's no blinding of the patient or of the assessor. So I'm not sure how much, how good those data are. But if we take them at face value that steroids somehow suppress nodules, then so for example, the Ketchum study suggested that the steroid injections may need to be repeated every so often. And I think that's entirely reasonable, because I don't think you can cure Dupuytren's disease. It's pre-programmed into the genetics and the epigenetics of the hand. So what you're looking to do is to control it. And so I suspect if patients were offered a treatment down the line that's approved by the regulator, whereby they could have intermittent treatment of whatever that is, then that may be acceptable to them, but the patient representatives are better able to speak to that.
There's a couple of questions in the Q&A relating to adverse events, Jagdeep. So one is, were they all localized, or were there any systemic effects? Another person has asked about effects on liver enzymes, etc. Could you tell us any more about the adverse effects?
So you'd expect something local in the sense that some patients may report swelling and redness, etc., following an injection of anything. But what I'm talking about is serious adverse events, grade 3 or above. So this is, for example, someone requiring medical intervention, hospitalization, etc. And there were no related adverse events in this trial, in any group, saline or adalimumab.
Okay, Great. And again, a couple of sort of related questions from different people. Is there going to be a need for a phase 3 trial? Sophie Reismeyer is wondering, will there be long-term follow-up of these patients as well? So can you tell us a bit more about what the future might hold?
Yeah, so I mean, obviously, I'm not in a position to speak for what the regulators might want. That's up to them. And I think that there's the question is actually slightly more nuanced, because this is a repurposing study for a drug that's well known. It's been used in over 5 million patients worldwide over a period of many years. So we know the safety profile of the drug. So it's not like a brand new drug off the ship that someone's created and is now being tested where of course it would be totally normal for the regulator to request not just one but 2 parallel phase 3 studies conducted in different geographical areas, etc. So it's really all about how does a regulator perceive this, and I made the point earlier on that phase 3 is typically based on clinical outcomes. So in other words, patient-reported outcomes, and we heard last week Jeremy Rodriguez's views on how well does, for example, flexion deformity correlate with that, not particularly well. So, and the problem with patient-reported outcomes is that in patients with early stage disease, so if you take the Michigan, for example, there's very little impairment because patients can still function pretty well. So so with those sort of instruments, you're likely to see a ceiling effect until the disease progresses to a very late stage. And under those circumstances, then you'd be looking at follow-ups of a decade or 2 decades, and I just don't think that's feasible. I'm certainly not able to do that. And to answer your question, is there going to be long-term follow-up of this cohort of patients? No, that's not planned. I think the patients have been incredibly motivated and to return, which is a huge problem for many studies, right? Because even in this one, it's 18 months of follow-up. That's a long time for someone to keep coming back at regular intervals. And it's all credit to the RID trial participants that they've given us, putting so much time and effort into this. So remote follow-up, etc., I think poses its own challenges, because how do you then assess things like nodule hardness, nodule size remotely? It's simply not possible.
Yeah, so it definitely has challenges, and maybe routinely collected data will come into its own as well at some point in the future. David, can I come back to you, because I know you've got a few more questions on the cell biology. So do you want to have another shot?
I have lots of questions, but I'll limit it to some very few. I mean, excellent work with the TNF, and I completely understand the reason you've gone down this road. It's very logical and sensible. I noted that both you and I have noted that these cells also produce relatively high levels of IL-6. Is it another potential target, do you think?
We tried inhibiting that in vitro, David, and didn't really see any effect. And as you know, just because something's elevated doesn't mean it should be targeted.
Absolutely.
So we've so just in the TNF arena, for example, there was a time when people thought it'd be a great idea to target TNF in patients with multiple sclerosis. Actually made patients worse, and similarly with heart failure. So there are compensatory mechanisms, and there's also downstream cascades, if you like. And it's interesting, Dominic, this is one of your favorite questions, isn't it? It's in terms of, you get one cytokine, why would the others not compensate? And I think it's an excellent question. But that's my next question. But I think it's, the way I look at it is, if you target the pivotal mechanism, then whatever happens downstream is kind of dependent on what's essentially controlling all of those processes. And this is in some ways exactly what was observed in rheumatoid arthritis by Feldman and Maney when they did their pivotal studies. that inhibiting TNF in vitro with cells from rheumatoid synovium led to downregulation of IL-1.
One more question.
Yeah, go for it.
The palmar fascia of these patients is obviously prone to pro-inflammatory responses. You would agree?
Yeah.
So is there any potential, do you think, for kind of even like pre-nodule formation, coming up with some kind of a treatment that would basically try and dampen the local inflammation in these patients, essentially to prevent even going as far as a nodule?
Yeah, so that's a great question, David. So I think that's where, you know, those most recent data, which are currently submitted for publication, might, you know, I'm just speculating now because we obviously don't have any clinical evidence for that. Because what I think is happening is those immune regulatory fibroblasts are the one that are attracting the immune cells. So, and then the myofibroblasts are downstream of the immune cells. So that's the pathway we've targeted so far. So if there were a potential for targeting those immune regulatory fibroblasts, then that would indeed have the potential to prevent the if you like, the recruitment of immune cells and their activities. But then, of course, the challenge would be, you know, how do you target them? Because you clearly don't want to be treating the entire hand, and I don't think oral therapy would necessarily, again, be beneficial.
Right, we've got a huge number of questions still from the audience to go. I'm trying to sort of group them together a little bit. There's a question from Elizabeth Laird and also Duca Brookstra about if you're going to give this to patients with early Dupuytrens, of course, not all of them are going to progress ever. And lots of people stay very stable for a long time. And Paul Verker and his group have shown this. Do you think it's going to be important to be able to identify those patients who are likely to progress for this treatment in the future?
Yeah, absolutely, because you certainly don't want to be treating patients who are quiescent. And Paul, if I believe I'm correct in saying that you found that at about 7 years, that about 20% of your patients progressed. And the study from Iceland showed that by about 18 years, 35% progress. So relatively speaking, it's you know, they're not large numbers. So we need some way of selecting these out. So for the trial, what we did was we asked patients, you know, can you tell us what's been happening to that nodule over the last 6 months? And if they gave a very clear history of progression, then that was part of the eligibility criteria. But it's not, you can't quantify that. And in the real world clinical scenario, unless you start measuring patients prospectively and assessing everyone over time, it's going to be incredibly challenging to essentially define a distinct population. There are no biomarkers, for example, you can use. You can't do a blood test and say, you know, this person's got active Dupuytren's versus somebody else who doesn't.
Yeah, okay. There's a couple of questions about the outliers. So I noticed as well on your 2A trial, when you had your high concentration dose of adalimumab, there were a reasonable number of patients who didn't show a response, although overall on a population level, you had a very clear response. Any ideas about what's happening there? There's a suggestion maybe there might be epigenetic causes or other possible reasons in those patients. Do you have any idea about the outliers?
No, so the kind of top line data for the phase 2B that I've presented are on the intention to treat population. So it's taken everyone together. And there are always some patients that respond better than others, and others that are non-responders overall. And in general, and I'm not talking about the RID trial, but for most treatments, roughly about 2/3 to 3/4 of patients respond pretty well, whatever your treatment is, right? So whether it's an antihypertensive or even anti-TNF for rheumatoid arthritis, it's roughly about 2/3 respond really pretty well, and then others are less responsive. So and that's a generality. Now, you know, can we somehow differentiate potential responders from non-responders, well, that's the kind of holy grail of precision medicine. And we're some way off that for most other conditions, let alone for Dupuytren's disease, where we're only just beginning to get these data now in terms of potential clinical efficacy.
Yeah, of course. A couple of questions from Heinrich Sagenschmidt, and also a similar question from Charlie Eaton. Do you really think that those driving forces are purely local within the nodules, or are they more systemic? And so Charlie says, you know, of course, we get associated with frozen shoulder and with Lederho's disease, etc. You know, this suggests that there may be more systemic driving forces behind it. What do you think about that?
Well, there's certainly no inflammatory markers that we've seen in the circulation, so in the plasma. You know, the alternative way to look at this is you've got the patient's genome as a whole, and then there's epigenetic modulation of that in certain areas. So certainly we've shown it in the palm. There may be a similar situation on the sole of the foot and the shoulder, etc. So right. Patients get frozen shoulder, but then they don't necessarily, not to my knowledge anyway, they don't have a greater propensity to develop, I don't know, fibrosis of the elbow or the knee. So I think that there are local factors that determine what's happening.
It's interesting, though. There are some clinical observations of patients who get stiffness after knee replacement being more likely to have Dupuytren's as well. So maybe there is something a bit more systemic going on. Okay, there's a question about saline injection. Do you think that saline injection itself could trigger the nodule to progression, and do you correct for that in the analysis? Sophie Reismeyer, that's from Iris Holt, and Sophie Reismeyer, as an addition to that, says it's known that mechanical forces can activate pro-inflammatory hyposignaling pathway.
Yeah, so I'm not aware of any data that suggests that saline injection can trigger it. I know of a publication suggesting that surgical excision of nodules can essentially lead to progression of the disease. So I think the insult probably has to be more significant than a solitary injection.
Okay. Right. I'm just looking through. There's a lot of questions I think that we can answer with typing, and I'm aware of time. Wolfgang Wack would like to know what the cost you might expect for Dupuytren's treatment is. Adalimumab apparently is quite expensive. I have to say I don't know the cost of it. So can you make a comment on that, Jagdeep?
Well, I'm not sure of the cost in other countries, but in the UK, each if you like, in pre-filled syringe or vial costs in the region of about £350. But I believe the costs are different in North America, for example. But you know, now I think costs are beginning to come down for all of the anti-TNFs or all applications because of the biosimilars.
Mm-hmm. So would you anticipate this maybe being given at regular intervals lifelong?
Well, I'd be speculating at the moment, Dominic. I think if you were asking me to gaze into a crystal ball, I think it would be, but I don't think you'd have to do it, you know, every year and so on. And so you know, this is coming back to Paul's question of you know, how often. I don't know how often until you follow patients for decades. But I don't think, you know, anti-TNF will not cure Dupuytren's disease. I'm not aware of how we could cure it. I think we can control it. Mm-hmm. Control invariably means, you know, intermittent treatment for any disease, not just Dupuytren's.
Okay, I'm going to just focus in on a couple more questions. Naz Rahman wants to know whether there were consistent reductions in nodule size over the course of the trial, or did the sort of reduction peak or trough, I suppose, at one point?
So those are data that I'm afraid you have to wait until the paper's published.
Okay, so just a reminder to everyone that when the paper's published and all of the data is available, it will be freely available, open access. We'll see if we can put a link to it when it's published on the Symposium website as well, next to where we put the link to the video and this discussion. So hopefully you'll be able to see it there. I think the remaining questions we're going to try and answer by typing, and I'm going to thank Jagdeep for a really excellent presentation and answering as freely as possible our Q&A. That was really fantastic. We're now going to just have a video from one of our, we'll give it a round of applause.